Hello, everyone. For the last part of this lecture series, we will be talking about bone metabolism. As you can imagine, inherently a big part of this is also calcium metabolism, which goes hand in hand with this topic. But I've already covered calcium metabolism in our lecture on pituitary stuff, so I won't be talking about that today. But if you'd like to, go check that one out. So again, I know you don't always have to go back to the same principle, but I like to because it makes sense. We will go back to looking at things at a smaller scale, understanding why they happen, because I think that saves time and makes more sense. So here on the right, you have bone. Okay, so as you can see, you have what seems to be, and again, I'll dumb this down a bit. I don't say dumb it down, simplify it to the point where you look at the picture and kind of makes sense. I would not say this is bone if I didn't know what this was. It looks like something that's pretty well organized. In the middle, looks pretty pink, and then we just have scattered stuff in between. So let's talk about what this exactly is. We have in the center trabecular bone, which is solid, as it looks pretty solid in my opinion. And as you can see, it's got these nice layers to it. And this sheet-like arrangement is called lamellar architecture. Kind of makes sense. Lamella just meaning organized and kind of flowing. And it's relatively organized, right? The lamellar bone, or this bone, is formed when primitive bone undergoes remodeling under stress, gravity, and movement. What do I mean by this? What I mean by this is that when your bone is formed, you don't start off with bone looking like this. You start off with more primitive bone, and that over time develops and strengthens, which is why when we talk about improving bone health, we always talk about activity, we always talk about stress-bearing movements and resistant exercises and so on. You also need to know that bone is always undergoing a process of building new bone and breaking down pre-existing bone. And this is due to the action of two main types of cells. This is really important to know. You have your osteoblasts, which build bone, and the osteoclasts, which break down bone. And we look at this further in the next slide. Between the bony trabeculae, you have bone marrow, right? And this is consisting of hematopoietic stem cells as well as adipose tissue. So looking at the picture, this is a recently fractured bone. What are some key differences between this and this? If we go back to just really simplifying it, even if you sound like an idiot saying it, that's fine, because that's really all it is about. So looking more microscopically, we can see that it's not lamellar. We can see that there are cells lining the membrane or lining the surface. And these tiny cells lining the surface are osteoblasts. So this is a recently fractured bone. And with fractures, there's going to be a big emphasis on building new bone. And that's going to be done by osteoblasts. And those are the cells that line the surface. Now, they produce something called osteoid, or osteoid is your uncalcified organic matrix. So if you go back to what bone is, it's a mixture of organic and inorganic substances. Organic are the ones which are heavy in carbon, and then you have your inorganic, which are the ones heavy in ions and minerals like calcium and phosphate. So first you produce the matrix. And when I say matrix, don't third-year matrix PTSD, that's fine. So you have your matrix, and that's produced of collagen or organic matter. Once you have that matrix, you then start depositing these hydroxyapatite crystals, which are composed of calcium phosphate, on this organic matter, and then it undergoes stress and further development to form nice bone. A few relevant points here. First is that you have a two-step process. Second point is that the bone, as you know, is composed of the two main minerals, calcium and phosphate. And if you have already watched the lecture on the parathyroid gland and calcium metabolism, you would know how important both of these are. It's not just calcium, phosphate is also super important. And these osteoblasts are the ones that are building bone. So blasts building. So let's talk a bit about what's going on here. Osteoblasts, osteoclasts, what's going on there. This is a bit confusing, so please stay with me. I'll try my best to explain it. We already know that PTH, or parathyroid hormone, breaks down bone to release calcium into the bloodstream to raise the calcium blood levels, the blood calcium levels, sorry. So we know that PTH is going to break down bone. Now, how does that happen? Firstly, osteoblasts have PTH receptors. Now, it may be a bit confusing because I just said that osteoblasts build bone. So why are we targeting something that builds bone? Right? Doesn't make sense so far, but it will. PTH binds to osteoblasts at receptors for PTH. Makes sense? The osteoblasts then release a hormone called RANK-L or rank ligand. You don't need to know what it is, just know that it's a thing that's released by osteoblasts under the influence of PTH. What RANK-L does, it goes on to cause, the binding of PTH to the osteoblasts causes osteoblast differentiation. Now, again, you might be just scratching your head thinking, Karan, you just said that osteoblasts build bone. Why is PTH causing osteoblast differentiation? You would be correct. But the important thing you need to know is because the process is so dynamic, when we start differentiating osteoblasts, we now have more mature cells that stay for longer and don't actually build bone because they are now more differentiated and more developed cells. Kind of make sense? So with the differentiation of osteoblasts, we're actually inhibiting their function. Furthermore, we have RANK-L or rank ligand, which binds to rank receptors in the pre-osteoclast cells. So you have your osteoclasts, and they come from a lineage of cells called pre-osteoclasts. And when RANK-L binds to them, it causes a rapid turn or increase in the turnover of osteoclasts. So now you have osteoclastogenesis, or the quicker production of more osteoclasts. These two factors combined cause more breakdown than production. Again, it's never one or the other. It's always which one is in overdrive. So quick summary, PTH binds to osteoblasts. Osteoblasts differentiate, lose their ability to produce more good bone. Next, it also releases RANK-L. RANK-L, released by the osteoblasts, binds to pre-osteoclast receptors, causing osteoclastogenesis, or their increased rate of maturation and development. And all this leads to increased destruction of bone instead of production. So let's look at a few conditions affecting bones. Firstly, we have osteomalacia and rickets. So osteomalacia and rickets are very similar conditions, and they both refer to disorganized bone calcification with poor density. So there are two things going on here. Firstly, you have poor density, so it means it's not dense enough, but it's also not big. The bone that you have is disorganized, it's chaotic, it's not as nice and structured with that deposition that we talked about. So the way I like to think about it is, let's say you have, I don't know, a farm and you're trying to grow crops. With conditions like osteoporosis, you just have lesser yields. You still have high quality crops, but in lesser amounts. With osteomalacia and rickets, you not only have lesser amounts, but the crops you're actually producing are actually horrible quality as well. So it's kind of a two-process thing going on. It is most commonly caused because of vitamin D deficiency, which we know has a very important role in calcium and phosphate metabolism. To your right, you can see here, we have bony trabeculae, which I talked about earlier, which are seen in black, and you have very thick layers of osteoid. The osteoid, as you know, needs to be mineralized to form good bone, and that mineralization is just not happening. Again, why is it not happening? Well, because you have vitamin D deficiency. Vitamin D helps absorb calcium and phosphate, and you need both of those to cause or to develop or build up bone. You don't have that. So you're going to be producing your organic matrix full of collagen, but it's not going to be mineralized by that hydroxyapatite. What does this mean? As you know, okay, before I get to that, sorry. So you have a lot of collagen, a lot of matrix, but you're not going to be laying down good bone. So what's the difference between osteomalacia and rickets? Osteomalacia is the disease when it happens in adults, while rickets is when it happens in children. In terms of severity, rickets tends to be worse because you have the disease when the bones are rapidly growing and you are growing. And therefore, it can lead to deformed bone formation, where not only do you have weak bones, but the bones themselves are physically deformed. And you can see a picture here where you have the classical bow-legged child who has rickets. Other features common to both include bone tenderness, increased fracture risk, disturbances with gait, as well as muscular weakness. Next, we have Paget's disease. Now, Paget's disease is this really interesting disease, in my opinion, where it's a metabolic issue where you have increased bone destruction and increased bone repair. Now, it may seem a bit counterintuitive and why that's pathological. We'll get to that in a second. It typically affects older patients and is considered to have a viral trigger, typically paramyxoviruses. Now, why is this even relevant? Like, why do we need a trigger? What's going on here? So what they hypothesize is that you have this infection, and for some reason, this infection causes your osteoclasts to go into overdrive. They have this hyper response for reasons I don't understand. And so now you have osteoclasts that are working excessively. Osteoclasts break down bone, so you're now going to be producing or breaking down bone really quickly. And your osteoblasts, which typically build bone, pick this up and then start building bone really quickly. But then, well, what's the issue? Because you're breaking down bone and you're building bone, why are we worried? Well, again, we're worried because whenever we talk about rapid turnover, it usually means that the new bone being produced is not going to be of a good quality. So you have poor quality bone that is structurally abnormal, even though you may have more of it. Symptoms of Paget's include bone pain, increase in head size. I know that's a funny one, and I'll show you a picture as to how that fits in. Skeletal deformities, as well as high output cardiac failure. Now, you may be wondering, why do you have high output cardiac failure? And interestingly enough, your bones, because they are so metabolically active in building and destroying bone, you have so much blood going to the bones themselves that your heart may go into cardiac failure. So this is what it looks like, where you have thickened bone, but that bone is not going to be of a good quality. And despite the thickened bone, you still are going to be at a higher fracture risk. And you can see here, the skull is quite thickened throughout, which is why you have the increase in heart size. On bloods, we don't observe any issues with calcium and phosphate. However, we do have raised ALP levels. Now, ALP levels are mentioned elsewhere. It's an enzyme we typically look at with LFTs. So why is it relevant here? In addition to having roles with the liver and the biliary tree, ALP is a marker of bone turnover. So any circumstance where you have increased bone turnover or bone destruction, including things like bony metastases as well as Paget's disease, you can have increased ALP levels, and this is typically treated with bisphosphonates. I'll quickly go back to, going back to osteomalacia and rickets. I'm sure this is self-explanatory, but I'll just go over the typical blood test findings as well. So you would see vitamin D deficiency, makes sense. You might see low levels of calcium and low phosphate levels, but this is going to be very, very rare because the PTH is very good at controlling the serum calcium levels. So although your body may not be getting enough calcium, the calcium in your blood is very tightly regulated. So don't let that throw you off. Likewise, with osteoporosis, where we have poor mineralization and just lesser density, there may be an issue with calcium supplementation, but that doesn't always mean the patient will be hypocalcemic. Moving on to osteoporosis. So osteoporosis is a disease of bone density, not formation. Risk factors include low exercise, smoking, female sex, old age, stereotherapy, low calcium, as well as low calcium intake and vitamin D deficiency. So a few things that I want to go over. Smoking, because it's a risk factor for pretty much everything. Low exercise activity, because as I said, that bone formation and increased bone density responds to weight-bearing activities as well as gravity. Female sex in old age, this is primarily because of the role of estrogens and progesterones in maintaining bone health. Estrogen helps maintain bone health. And when you have reductions or drops in your estrogen levels with menopause, you can have a rapid decline in bone density. Steroid therapy as well, because steroids, or exogenous steroids in most cases, act on both osteoblasts and osteoclasts. They prevent the formation of osteoblasts and prevent the breakdown of osteoclasts. So now you have a deficiency of new osteoblasts and too many osteoclasts that aren't being broken down. Both of those cause an overall bone loss. It is a very, very common. 1.2 million Australians have osteoporosis and 5.4 have osteopenia. And as you can imagine, osteopenia is just the stepping stone for osteoporosis. In terms of how we diagnose osteoporosis, we do something called a DEXA scan. And we look at T-scores. Now, what are T-scores and how are they different to Z-scores? Again, Z-scores may be a soft spot for any Monash, for the Monash kids watching this. So how do the two compare? So Z-scores look at how your bone, how many standard deviations away your bone density is from people of the same demographic, same age, versus T-scores, which compare this to a healthy 30-year-old sample. Does that make sense? How would that be relevant? So let's say the average bone density of an 80-year-old female may be, let's say, osteopenic, right? She may have, most 80-year-old females are going to be osteopenic. And if you were to look at their Z-scores, well, most of them would have a normal Z-score because all of them are osteopenic, right? But that doesn't mean that they don't have osteoporosis, which is why we want to compare them to what a healthy 30-year-old sample would be. I hope I haven't confused you too much with that. So the normal range is anything greater than -1 is normal. Osteopenia is -1 to -2.5, and osteoporosis is -2.5. And here is a DEXA report. So you report both the T-score as well as the Z-score. And the T-score in almost all cases is going to be more severe than the Z-score, because again, you're comparing it to a healthy person who's 30 years of age and not a person of the same age. One thing that really confused me was in a DEXA, we look at various bones. We look at the neck of the femur, the trochanter, we look at the humerus, we look at the wrist. Which density are we looking at? And the answer is we're looking at the worst one. So we look at a few ones, as I mentioned, as well as the vertebrae, the hip, neck of femur. So whatever the worst score is taken as their T-score. How do we decide on when to treat patients? So this is a very complex process that I don't think you need to know much about, at least until next year. This depends on things like their age, demographic, their DEXA scan, their fracture risk, whether we are aiming for primary or secondary prevention, meaning have they had a low impact fracture before, and therefore now we want to treat them, or are we just preventing any fractures to begin with? And then factors specific to each medication. So the options we have include oral bisphosphonates like alendronate, IV bisphosphonates, denosumab, which is a subcutaneous injection, hormone replacement therapy with estrogen or progesterones if patients have menopausal symptoms, and teriparatide, which is again a subcutaneous injection. The most common ones you should know include bisphosphonates. You can give this either oral or IV, and can be given either weekly, monthly, or 3 to 6 monthly as well. One very important complication you should be aware of with bisphosphonates is osteonecrosis of the jaw. It is a very rare complication, but is really, really severe if it does happen. Other things they should be aware of is when you instruct people on how to take oral bisphosphonates, they should take this usually first thing in the morning on an empty stomach. They should after taking the medication, they should be upright for at least 30 minutes. Obviously, bisphosphonates help build bone, but you are not going to be building bone if you don't have the basic materials or to build said bone, which is why we also almost always would like to supplement vitamin D as well as calcium and talk about lifestyle improvement. So the same SNAP-W that we've always talked about: smoking, nutrition, alcohol, physical activity, weight management, and especially when we talk about exercise, we want to maximize that weight-bearing exercise and resistance training if they can. Here is also a good flowchart, which now I realize is looking quite distorted. Apologies for that. If you just look at RACGP, that kind of indicates what the or what the thresholds for treating osteoporosis should be. Let's just go with a very typical case. So let's say you have a patient who has no history of minimal trauma fracture. So we're aiming for primary prevention. Let's say the patient is above 70 years old. The thing we would look for in particular would be their T-score, as well as assess their fracture risk. So if they have a T-score that indicates osteoporosis, we might consider osteoporotic medications like bisphosphonates, which are grade A. Alternatively, if the patient is less than 70 years old and has significant risk factors for fractures, including things like obesity, steroid therapy, and so on, we might estimate their absolute risk. And if they have a high risk, or if they have a T-score more than 2.5 above the age of 70, as you can see here, estimate their absolute fracture risk. If it's high risk, then start treatment. But if they are less than 70, do not have any risk factors, or have a low or a mild or medium risk of fractures, we don't recommend treatment in those cases. I hope that makes sense. And that is all we had for bone metabolism. As always, please feel free to get in touch if you have any questions, and look after yourself and look after your loved ones.